Became involved with the state's pregnancy-related depression work during the development of the Health Team Works guidance, and we are honored to have her speaking at our event. So welcome, Karen. Thank you.
Good afternoon. So I'm a reproductive psychiatrist, which at some point is going to be its own fellowship with training. But at this point, it's just people in psychiatry who are interested in particular in women and in the intersection between hormones and psychiatric disorders. I actually had a very circuitous route to becoming a psychiatrist. I went to medical school to become an OB-GYN. After briefly thinking I wanted to be a midwife, and went to medical school, did 2 years of an OB-GYN residency, and was pregnant with my second child, and my husband was diagnosed with cancer, and I just couldn't do it. I was trying to do it all in my third year of OB-GYN residency, and I took some time out, and I worked as a GP while I was finishing my pregnancy, and I realized that my passion was the mind-body connection. And I saw so many people in general practice who came to me, say a man with a back injury, who a lot of his problem was that it was such a hit to his ego that he was in pain, that he couldn't figure out a way to get better. And so he was stuck in a cycle of feeling helpless and in pain and not knowing where to get help. And that is true for basically all illness. At some point I have a dream that mental illness won't be partitioned off as something so different from all other kinds of illness. Anyway, I ended up... Oh, I'm sorry. Okay. Is this better? Yes. All right. I ended up being inspired by someone who who's a psychiatrist who ran an OB Psych clinic while I was an OB-GYN resident, and I could see this huge need for our OB patients. I was running to try to get them in, to advocate for my patients, to get them in to see the doctor, and that's what inspired me to go into what I did. So I switched over and I did a psychiatry residency. And this was all in Houston, Texas, and right around the time of Andrea Yates. I just want you all to know I'm not connected to any drug companies. I don't speak for them, etc. And I also did psychoanalytic training. So I'm going to throw in a quote from D.W. Winnicott, who was a pediatrician who ended up working with a lot of mothers with children. And he came up with the theory of the good enough mother, if you all know what that is. And one of my favorite quotes from him is basically saying it's not possible to look at an infant and understand the infant's well-being without looking at the mother. And that's how I view working with a pregnant and postpartum mother, is not only is it a women's sort of rights issue that her struggles should be identified as well as the infant's health. That is part of my passion, but the other part is, if she's doing well, bottom line is, the baby's going to do better. That's a very common sense thing, but with all the research that we have on treatment of mood disorders during pregnancy, that basic idea that if the mom's feeling well and doing well, the pregnancy's going to go better, delivery's going to go better, and her postpartum period's going to go better. So don't look at the baby without looking at the mother. We don't need to put them at odds with each other either and think that her well-being should be sacrificed for the infants, because that's not actually true. So I am a huge fan of mindfulness, exercise, diet, spirituality as a part of mental health. However, I also see sometimes that medication is an instrumental part of a wellness plan. And some people need medication in order to get to the point where they can get out of bed and find the motivation and the energy and the concentration to do the other things. So these are the questions we're going to address. I'm not going to read them right now. This slide will show up later. Big picture is psychiatric medication are some of the most well-studied of all medications during the reproduction period. I think that's partly because they're seen as optional, as opposed to, say, a woman with a seizure disorder who, it's a no-brainer, she's going to have to be on an anti-seizure medicine in order to have a healthy pregnancy. So you kind of throw out that concern, you give her an anti-seizure medication, and you hope for the best. And we have a lot of data about the safety of anti-seizure medicines because they've had to be used. But with psychiatric medicine, there was sort of part of the stigma, I think, of psychiatric illness is that you're just thinking wrong, and if you think better, you will get better. And that's not always true. It can have a very biologic basis where medication is a part of a person's being able to do all those other things. Anyway, we have, I was going to add up how many thousands of people we now have data on, but it's in the millions. But bottom line is, there have been studies since the 80s looking at psychiatric medications and pregnancy and postpartum period. Most of the studies, even now, are case control retrospective studies where they're taking a huge database like the country of Sweden, literally. The Swedish the Swedish system has a wonderfully organized, computerized data set, and people will come, researchers will go and look at, let's see how many women took an antidepressant during a pregnancy, and then let's go back and see, and then let's see what outcomes happened, and is there any correlation. The problem with those kinds of studies are that there's very little data about what was going on in that woman's life. Was she being beaten at home? Was she smoking? Was she drinking alcohol? What was going on apart from her exposure to the medication? And the other is that often what was going on is all basically an interview with the person over the phone, or oftentimes it's just whether they filled the prescription or not. So a lot of those, like the most recent study has been an association between autism and SSRIs, which is going to upset everybody. But that study is coming out of this kind of research, which is basically number crunching. It's very nonspecific. And I just want to give you an ability to filter and understand when you hear some headline like, there's an association between X and SSRIs. There are some people do prospective data reviews, which is just, rather than looking at an outcome and then going back, it's still large numbers of people and it's still not really knowing what's going on with that woman, that specific person, but it's going prospectively, just to help you understand that. A few are prospective observational studies. So we can't do case control where we have a placebo in pregnant women. That's illegal. Instead, there are some studies that take women who call in, say, to a place like the Massachusetts General Hospital Women's Program, who call in and say, I'm on an antidepressant, I'm thinking of getting pregnant, what should I do? And they say, well, we'll counsel you, but can we also study you? Will you be in our study? And we'll follow you and see what happens. And so there are some good studies that have given us some very helpful information about the decision whether to go off medication or not, for example. There are tons of meta-analyses, which is basically people then studying all the other studies. And the more recent studies, and Dr. Rice brought one up earlier today, are studies that are far more intelligent. They are comparing exposure to antidepressants with exposure to depression or anxiety or bipolar disorder, or whatever the underlying condition is that the woman is trying to decide whether to go off a medication or not. There are a lot of other studies that are also looking at biomarkers, such as cortisol, blood pressure, adrenaline, heart rate variability, a lot of biomarkers of stress that are now being identified. And then we're talking about the complexity of genes in the environment, because not only we have a genetic blueprint, but whether genes get turned on or off is partly dependent on our exposures. In other words, our environment, our life experience, exposure to toxicity, to toxins, things like that. And this is called epigenetics. And anyway, the studies these days are far more intelligent and nuanced, and there are going to be a ton more of them. I wanted to give you this. This is the American College of OB-GYN's opinion on psychiatric medication that was published in 2008. And it's very measured. It was actually written by OB-GYNs and psychiatrists together. And they basically said the potential risk of using a medication, SSRIs in this case, throughout pregnancy needs to be considered in the context of the risk of relapse of the underlying condition. And then there are some specific issues that they addressed. One is paroxetine or Paxil, which Dr. Rice brought up, and I'll give you my 2 cents on that. Paxil became identified in those large retrospective database studies with heart defects. And so at this time in 2008, there was a recommendation for women to get off of Paxil. That's going to come up later. The other one is, who has heard of PPHN? Okay, some people. It is, I always forget what the first P is. It's persistent pulmonary hypertension of the newborn. So it's a very heterogeneous disorder where it's a failure of the lungs of the infant to expand, and therefore for the blood circulation to open up right after birth. So one of the miracles of life is that a baby goes from breathing water and having their lungs filled with amniotic fluid in utero, receiving oxygen through the mother, through the placenta, goes in a moment after birth, takes a breath, lungs expand, and the pulmonary circulation opens up, and the holes in the heart that were shunting blood to allow for that in utero circulation have to close, and the heart begins to beat the way yours and mine does. And PPHN is basically a heterogeneous spectrum of disorders where basically the lungs don't expand, and therefore there's hypertension, meaning that the circulation in the infant's lungs is blocked, is closed down. But it's not just the circulation, it's not just about blood pressure, it's about the lungs not expanding. But anyway, I have a lot of patients who come to me saying, I won't take a medicine because of this concern about PPHN. And it's unfortunate because we'll get into the studies of whether it's an actual risk or not. But basically, it's looking like, no, PPHN occurs out of things like cesarean sections, larger BMI mothers, or heavier moms tend to have babies who have more breathing problems. C-section, meconium aspiration, those sorts of things, they're all confounders. And we know that women who are suffering with depression and anxiety during their pregnancy tend to have more C-sections, tend to be heavier. The meconium is sort of just a sign of distress during the delivery. Anyway, the connection then is not causal between the medication and PPHN, but it's something that a lot of moms, if they hear about it, they think they're in control because they know about PPHN. Anyway, And the last issue here is about perinatal adaptation or withdrawal or toxicity. These are all questions about the exposure of medication and whether the babies are going through withdrawal from an SSRI. Are they struggling from serotonin syndrome or something else that is connected to the medication and they're not doing as well postpartum. So that was in 2008. Today, it's not published yet, but the Agency for Healthcare Research and Quality, which is an aspect of the Department of Health, Health and Human Services, one of 12 of their divisions, is coming out with a statement about medications during pregnancy and the postpartum period. And as the bullet point, the first one is they go into detail as to the risks of untreated depression during pregnancy. I'm not going to read it all out, you have it, but basically it's problems with the pregnancy, problems during delivery, and problems postpartum. They pose 3 questions. What are the comparative benefits of medications and non-pharmacological treatments? What are the comparative harms? And what patient characteristics and intervention characteristics, provider characteristics can predict a positive treatment response? So it's a really encompassing, wonderful study that's going to be available on their website at some point soon. What they found is frustrating in that it's still saying we don't know enough. They say very few studies show direct evidence for outcomes of antidepressants, and that means outcomes, positive, negative, etc., everything. Direct evidence being those good studies where you know the characteristics of the people in the study. They're not just database mining. Then they rate the studies using indirect evidence, and they identify indirect evidence. Aspects of those studies are that the women taking the antidepressants are taking them for multiple reasons, not necessarily just one condition like depression. And then they're being compared to women who not only were not on antidepressants, but they don't have a mental illness. And we don't know the characteristics. Was the mom taking medicine and still sick? Or was she taking medicine and feeling good? Was she smoking? Was she drinking alcohol? The randomized controlled studies meeting criteria for efficacy have drawbacks in that because they're so small and specific, they don't have adequate power to be statistically significant. They try to normalize and specify the characteristics of the study patients, and therefore they do things like they won't accept people into the study who have more than one illness. And how many people do we know who have only depression is the problem. So it's a very unnatural group that's ultimately being studied. People who have alcoholism in their past plus depression aren't allowed in the study. So it's not very natural. And the last frustrating thing, the studies of non-pharmacological treatments, and that includes massage, acupuncture, mindfulness-based treatments. They say basically there's a lack of detail of the characteristics of the treatment, so we can't really say that much about them. So again, I think what this is saying is what we can know is limited by what we can study. It doesn't mean we don't know anything, though, is one of the take-homes I want you all to understand is there are so many bright people doing studies on all these different treatments. And just because in the end we can't say for sure we know, doesn't mean we don't have a good idea. So their ultimate conclusions are that pharmacologic treatment for pregnant women may confer benefit. And regarding harms specifically, they identified that there is direct evidence for respiratory distress, but that's different from PPHN. And there was a concern a long time ago about neonatal convulsions, and that's definitely proven. We have good enough direct evidence saying no, SSRIs don't cause neonatal convulsions. 5 quality but indirect studies, and a quality study has a low bias, has a systemized classification of malformation. That's huge. A lot of the studies, those data mining studies, part of the problem is the outcomes aren't regulated. You really need to have a good study about malformations. You need to have an educated pediatrician doing a very good evaluation of the baby, a very thorough evaluation. And a lot of times, that's not what you get. You get something that's not, you get different pediatricians' opinions about what's going on with the baby, and it's not really validated. Anyway, and controlling for confounders, the confounders are things like smoking, weight, socioeconomics, things like that. They found no evidence for association of SSRIs with malformations in general, and specifically with cardiac malformations, and this includes paroxetine. As far as this question of adaptation syndrome, whether the babies don't do as well, we're still not sure, basically. Some studies show no difference, some studies do. It looks like it's around 30% of babies is kind of the, not in this conclusion, but in other, sort of the going wisdom right now is it looks like about 30% of the babies might have what's called neonatal adaptation syndrome, where they're a little twitchy, they may have apneic spells, they may need a little more support. It's transient, it's not life-threatening. It makes us uncomfortable, but it's temporary, and it shouldn't be the thing that makes the decision whether you take a mom off medicine or not right before she delivers. And finally, regarding breastfeeding, they just throw it out there. They say encourage concurrent breastfeeding with SSRIs. Negligible amounts get through breast milk in the medications that we've studied, which are not the newest ones, but everything else, including Effexor. All of the SSRIs, 1/10 of mom's blood concentration of drug or less is in breast milk. And there have been plenty of really good studies following kids out exposed through breast milk to their to 9 years old is one study I'm aware of. And there's no evidence of adverse events. So really, I want to take breastfeeding off the table as something that should be a make or break. It really doesn't need to be that way. If a mom needs to take medicine and really wants to breastfeed, she can. Is a take home that I'd love for you all to know. All right, regarding respiratory distress, that's what I was describing with the neonatal adaptation syndrome. It is not PPHN. So what we know about PPHN is that the incidence of it is 2 in 1,000 in the US in general. There have been 6 indirect studies with conflicting findings. 3 thought that there was an association between SSRIs and PPHN, but they disagreed as to when the exposure was important. One study said the exposure had to happen before 20 weeks gestation. The other study said it had to be in the last half of pregnancy. 3 found no association. Of all these studies, if you add them all up, we have 50 babies with PPHN out of 25,000 who were exposed to medication, which is a 2 in 1,000 incidence, which is equal to natural all comers. Okay? So, This is sort of an embedded slide. Depression in the US for everyone is the lifetime, the 12-month incidence in the US is 6.7% for depression. So 6 to 7 out of 100 people in the US have depression.
Irregardless of pregnancy?
Yeah, this is men, women, everybody. Anxiety disorders, higher incidence, 18.1%. Generalized anxiety and social anxiety are far more common than OCD, and panic disorders close to generalized anxiety. So the question is, so what happens? Both of these I'm going to lump together from here on out as stress. One researcher, Catherine Monk, likes to call it distress. So she uses maternal distress as a term that lumps depression and anxiety together. We're looking at things like dysregulation of the hypothalamic pituitary axis, such as increased cortisol, fight or flight symptomatology. Alterations in immune response are huge, because when we have an immune, when we're upset, we know that our immune system gets affected. That's a huge area of study, because certain cytokines that are released by our blood vessels that cause inflammation, they cause a breakdown of the blood-brain barrier. And so that means that things that normally are protected from getting into the brain circulation get through. That's one of the big areas of research. And we know that during a stress response, our immune system is both activated and suppressed. And finally, just part of the fight or flight symptomatology is constricted blood flow. So all of those things, what does that do during pregnancy? So this slide also, so now I'm talking about pregnant women. The statistics are for pregnant women. For major depressive disorder, I'm using a very conservative estimate of 10% of women. If you add women who meet criteria for depression but not for major depression, that goes up to 18%. So 18 out of 100 women. And then for anxiety disorders, 13%. So really not an increase statistically from general population. What is interesting is OCD doubles during pregnancy and triples postpartum. So the question being, and Time magazine did an article a few years ago that had a pretty cool picture. I think it's cool because the mom looks like a fetus. And the question, and what they're talking about is how pregnancy might affect the health of a child adult. The fancy name for that is fetal origins of adult disease, or FOAD. So one of the things we need to ask is, which is worse, to expose an infant to the stress of a mood disorder or to an antidepressant? That's the burning question in my mind. And there are lots of studies that are still trying to figure that one out. The bottom line is there is no gold standard, black and white treatment protocol for all people. You need to sit down with each person, each woman, and figure out what is going to work best for her. Sometimes if she has a lot of social support, if she's done some psychotherapy and she has a framework for taking care of herself, she may be able to go off medication and do fine. Some women who are having a lot of stressful events in their life, they have poor social support, medication, or they've just not done well every time they go off their medication. Those are the women who, it's not optional, they need to stay on their medicine. Some of the things in the studies that are being looked at are uterine blood flow, maternal corticosteroids, and how that affects the corticosteroids in the infant. The placenta is this amazing organ, it's an endocrine organ, and it responds to increases in mom's cortisol by changing, sending messages about corticotropin releasing hormone to the infant, which can then, we know that heart rate variability is a healthy thing, and that when we're under stress, our heart rates tend to not be variable. There are good studies that show that meditation is very helpful for increasing heart rate variability, for example. exercise as well. But anyway, that's something that we can measure and is being looked at. I'm going to go ahead and keep moving. One thing I want to bring your attention to, the ALSPAC study is an ongoing study in the United Kingdom. It's a prospective study looking at families and following those families through to, at this point, where the kids are teenagers. It's an amazing study, and there is a lot of research that is coming out. There are some papers that have been coming out looking at what was going on during the pregnancy of the mother and then what the kids look like. And one study is the study that I quote, where mothers with high levels of anxiety during late pregnancy produced a higher rate of children with behavioral and emotional problems at ages 4 to 7. A more recent study just published, it again uses the ALSPAC data, looks at pregnant women, compares them to their partners, which is brilliant because they're controlling for, the mom is going to be intrauterine effects and the dad is going to be general environment in the home. So if the family's going through a stressful event, both of them are going to be anxious, depressed. If it's more sort of a biologic or internal experience for the mother and the father's not having it, they can then look and see how the babies, what the outcomes were. What they found was a positive association between antenatal depression and behavioral and attentional problems in 3 to 4-year-olds. What they also found was that there were confounders postpartum if a mom smoked, if they were lower socioeconomic status, and if mom had postnatal depression, the children did even worse. So this ideally, this is kind of this whole talk, this whole day is talking about these aspects. And sometimes it looks like this, but sometimes it looks like this, which is that a mom isn't going to be able to go to sleep and therefore begin to feel better and be able to start to talk with her support system, be able to eat, be able to exercise until we add a medication that gets her to sleep, for example. Something very simple. Just want to tell, the current FDA categories are very unhelpful and misguiding. They lump way too much. They don't assess for the quality of the studies, and they look mostly at animal studies, which interestingly don't correlate with malformations, at least in humans. So very unhelpful. There are new FDA categories. The FDA sort of prematurely announced they were coming in 2008, and they're still not here. But they're coming. And these are going to be far more helpful to all of us, where they're really being able to look at the quality and the quantity of the studies, compare risks of maternal illness and exposure to medication, and just assess the data. One thing I wanted to talk about are benzodiazepines, anxiolytics, Ativan, Klonopin, etc. They've gotten a really bad reputation, and there's certainly a medication I call them to respect. Someone on them needs to be monitored very closely. You don't want to just hand them out. But sometimes, in my experience, I just want to give you this as a clinical pearl, sometimes they make the difference between a woman being able to get on an SSRI, because initially if you're very anxious and you go on an SSRI, often it makes the anxiety worse. And giving a woman a low dose of an anti-anxiety medication for the first 3 weeks until the SSRI begins to work makes the difference between a failed outcome and a positive outcome. Often I see women who have been put on an SSRI by their primary care and told, we'll see you in a month. They went home and they didn't sleep for 3 days. And they're a mess, and their symptoms get much worse. And that could have been prevented with a monitored, very low dose of a medication to help her get to sleep, bridging her until the medication starts to work. A long time ago, benzodiazepines were associated with oral cleft, and what I want you to know is the ultimate number is 0.7% for oral clefts and cleft palate, cleft lip. In the general population, it's 7 in 10,000. So it is an increase, but it's still only 7 in 1,000. And it's only during the period of vulnerability when the face is forming, which is very, very early in pregnancy. So apart from that, there aren't any issues with benzodiazepines and teratogenicity. The other question is, does it affect brain development? And studies are more and more reassuring. This is an old slide, actually. Again, this isn't something to, it's not that every woman needs to be put on an anti-anxiety medication, but it's also not a deal breaker, there's no absolute black and white rule that a woman who's pregnant or in the postpartum period breastfeeding shouldn't be given an anti-anxiety medication. I'm going to go ahead. Bipolar disorder I wanted to address because it is highly associated with postpartum psychosis. And it's one of the things I know we're all very afraid of. We don't want a woman that we're caring for to have a terrible outcome. And it's a nightmare. We don't want a woman who we run into contact with to hurt or chill out, for example, is the sort of nightmare. As was earlier explained, the vast majority of women who are anxious and worried about hurting their babies have postpartum OCD and aren't going to hurt their babies. They're at no risk for hurting their babies. And most women who present with that worry, the fact that they're even presenting with it and being honest about it is sort of showing that they have more of the anxious OCD symptomatology. But the bottom line on bipolar, I just want to isolate it. It's something that women need to be treated for and followed very closely during pregnancy and then postpartum. And the risk is for a really bad outcome postpartum if she's not stable.
Use a comparison of the risk of the medication, say like atypicals or whatnot for baby during the perinatal postpartum?
You mean exposure in utero or?
In utero and breastfeeding.
Okay. So the main treatment for bipolar disorder are mood stabilizers. Lithium is the gold standard. And then the others are atypical antipsychotics and antiepileptics like valproate and carbamazepine. The risk, more recently, by the way, I just want to bring up Lamictal or lamotrigine is a mood stabilizer that has very reassuring data, but it's tricky because during pregnancy, the high levels of estrogen increase the clearance of Lamictal by double. So a woman whose treatment dose was, say, 200 milligrams of this medication, Lamictal, during their pregnancy, they may need to go up to 400. And so that's just something to know. Regarding the risks of teratogenicity, lithium got a bad rap for cardiac malformations. And the actual incidence of it is, so with lithium, the incidence of cardiovascular defects is 1 in 2,000 to 1 in 1,000 with first trimester exposure. It's very low. The main issues with medications are basically the kind of tried and true carbamazepine, which is Tegretol, has a 1% incidence of neural tube defects. And Depakote, or valproic acid, is the worst one. It has a 1 to 8% incidence of neural tube defects. I want you to think about, though, that the neural tube closes at 21 days pregnant. So gestational age 21, pregnancy 5 weeks pregnant. So often, by the time you are seeing a woman, she's beyond 5 weeks, and this whole issue is done. It's either happened or it hasn't. The worst thing you can do is take her off her medication abruptly, because we know statistically that those women are going to relapse, and they're going to relapse really fast. And once a woman who has bipolar disorder relapses, she's going to relapse again and again. It's very difficult to stabilize, so you want to prevent. And that means not having a reactive, knee-jerk panic and taking someone off medication. So what do we know about safety? We know a lot. Some of the studies are higher quality than others. For SSRIs, basically it's very reassuring data overall. Of course, not every woman needs to be on an SSRI. Right now in the US, about 10% of pregnant women are on SSRIs. We know that. So we're getting a lot of natural study because it's happening already. And that's probably a good thing, because when we look at those statistics of how many women are depressed during pregnancy, it's pretty high. It's around 10%. As far as things like lithium, we went over that a little bit. Lithium is really, in my field, you need to have a specialist following the woman, but basically lithium is, for a woman with bipolar 1, is the recommended treatment. For a woman with bipolar 2, Lamictal. Are some antidepressants safer than others? No. No. And I say that because I see a lot of women who have done really well. They have a history of having been put on, they've had trials of 3 different SSRIs. The one that really worked for them was Paxil. And then they want to get pregnant, or they are pregnant. And their clinician panics and says, no, you have to get off of Paxil. And that's not true. And you're putting it, especially for a woman like that who hasn't done well with other antidepressants, it makes no sense. Does it make sense to avoid use of antidepressants during certain stages of pregnancy? No. And especially, you don't want to take a woman off of an antidepressant in the 3rd trimester. That there have been really good studies. There was a concern back in late 2000s about neonatal abstinence syndrome, and the FDA even made a recommendation that women be considered to be taken off of their medication before pregnancy. There was an excellent study out of Italy that showed that women who were taken off their medication, their babies looked the same, and there was no protection for this sort of neonatal adaptation syndrome. It's a really bad idea, because if a woman needs to be on medication, you don't want to take her off of her medication right before she delivers. She's very vulnerable at that time due to the hormonal drop after delivering the placenta. That makes no sense. Again, all of this, if a woman really wants to go off of her medicine and she's doing really well and she's in a good place, she could choose to do that, and you could support her in that. But there's no hard and fast black and white recommendation to go off. Keeping the dosage as low as possible important, yes, with the caveat that you don't want her to not be treated. The worst thing would be for a woman to be on an antidepressant and still symptomatic. That makes no sense. Also, the pharmacokinetics during pregnancy change drastically, and clearance, both the medication gets diluted in mom's blood volume, and also our bodies are amazing during pregnancy, and they clear stuff really fast, including medication. So often, dosages have to be increased throughout the pregnancy in order to maintain wellness. What are the risks if antidepressants are not prescribed? We've discussed that. Alternative treatments, absolutely. And they shouldn't be alternative, they're actually both end. I don't ever think a woman should just take an antidepressant. I'm going to talk to her about mindfulness practices, about exercise, about sleep, about diet. But medication is a part of that as well sometimes. And then I was going to do some cases, but no time. Thank you.